FA. The upper endoscopy showed irregular mass occupying the body and the fundus. The CT showed that a diffuse circumferential polypoidal urothickening of the stomach reaching the pyloric canal.
See, baby.
The carcinoembryonic antigen was 7, and the CA19-9.
You can see the mucosa getting thicker. We're back. Okay. All right. Good morning again. So this gentleman has a gastric mass, which endoscopically I didn't even want to look at, but I guess we'll look at it. But you can see these thickened folds here. It's very suspicious. It's very rigid. So you know this is basically either a linitis or a lymphoma or some type of other infiltrative process of the stomach. A little bit of blood there. So on the EUS. Right away, if I go towards the gastric wall, you can see that the gastric wall here is very thickened. Let me show you some normal gastric wall over here. Okay, and then it starts to get thickened here, and you can see that you want to look at what we call the transition zones to see which layer is getting thickened. And to me, this is the mucosa here that is getting thickened here. Okay, very dark. And then as I pull back, you can see very gross thickening. You cannot see the serosa. You can see also in this patient some huge lymph nodes here, very malignant appearing lymph nodes, as well as when we were looking earlier. I want to show you in these cases, if you're thinking of a gastric cancer, you want to look for ascites, and it can be extremely subtle. And so he did have a small amount. Let me just see if I can find it for you.
I think there's,
Could you give us a differential diagnosis?
Yeah, I say adenocarcinoma versus lymphoma. That's pretty much it as far as unless there's some type of local pathology that you see more than we see in North America. I'm just looking for some ascites because he had some pretty obvious but very small pockets of ascites. I think it's important that you see, okay, well, I'll tell you right in here, there's a very thin line of ascites right here, but we had some more, no, don't turn it off, okay? There's a very thin line of ascites here, but he had some little triangles of, when you see the back wall that's irregular like this is what you get with very early ascites. Okay, and right in here, this type of thing, but it's not as clear as it could be. I'm looking for some more. He really had some obvious ascites before. And don't forget, with a gastric cancer, or a patient you suspect of gastric cancer, right here, okay. You can freeze that right there. Okay, this right here is a small amount of ascites. So there are some studies, for example, from Hong Kong, showing that the relative risk of having carcinomatosis right here, more ascites, is about 17 times higher than normal when you have this finding. So it's a really important finding to look for. Also, don't forget to look in the mediastinum for mediastinal nodes and at the liver for liver mets as part of the global staging. In a small proportion of patients, you will find mediastinal nodes, and if those are positive, that's clearly stage 4 disease. Now, in this gentleman, I can't, I can needle these nodes here. The big nodes we saw behind the tumor, you don't want to needle through the tumor because you can get a false positive. Although in this case, we're just looking for a diagnosis. So it doesn't really matter if I go through the tumor or not. But he does have a lymph node here, which I would like to biopsy. If I can, right here. Yes. And the mucosa here is not too abnormal. And I will tell you that in my experience, in patients with proven linitis, the FNA is often negative, just like the endoscopic biopsies, because the cells tend to be interspersed in the stroma, and it's hard to get packets of cells. So you actually may have a better yield by biopsying a lymph node than by biopsying the wall. So there's the lymph node. I'm going to put out the needle. The sheath is out there. You can see the sheath. Okay, and then there goes the needle through the wall first. Okay, because these nodes tend to be mobile, so I go through the wall first, then get into position on the node. Into the node we go, and it's good to do a fast stick and stop. The worst thing you don't want to do is slowly be pushing in, because then you'll go about 8 centimeters and you'll never see the tip. If you want to do it quickly, go in and stop, and then once you're in, look for the tip. And you have to roll your shoulders to find the tip. I think this is the new Wilson Cook, which has a really super echogenic tip. It's really very nice. So I'm doing some back and forth movements here. Okay, and then I'm going to put some suction on in just a second, not right now. So I'll put the suction on, and do a little bit more, and then we'll pull the needle back. Okay, so that's it. And then what we'll do in this case is we'll continue. If you had a cytologist, we could look at that right away. If not, I'll just do more biopsies and do some of the wall as well. As I say, I can't biopsy the ascites because I'll have to go through the tumor. But again, in this case, in a sense, it's not really important because we're just looking for a diagnosis. But I think this patient probably has some type of adenocarcinoma. When you get very dark lymph nodes like this with complete destruction of the architecture of the node, that is more characteristic of an infiltrative process like an adenocarcinoma rather than a lymphoma. In a lymphoma, I find that the architecture of the node is preserved and the node is large, but you still see the septation in the nodes. And these look like a really metastatic adenocarcinoma nodes.
I have a question.
Yes.
What did you define about the layer of origin of patient? What's the deep feature?
Yeah, what you want to do is find some normal mucosa here, and then pull back, and then look at the edge of the tumor where the transition zone is. And initially, I think I tried to show you that I thought it was coming out of the mucosa. The problem is, I find that with a linitis, it's really sort of a diffuse infiltration, but I think here you can see, here's the mucosa, and it's the mucosa, I think, that is getting thickened there. This what, sorry? I think it's primarily mucosa, but it's extending all the way through the wall down to the muscularis. So it would be at least a T3, a T2 lesion, but because the back wall is quite irregular and because I don't see the serosa, that's a T3, at least. Now, if he has ascites, that's M1, M like Mary. And if he has nodes in the chest, that would be M1. But the peritumoral nodes, if they're less than 2 centimeters away, are considered N1 and more, I think, than 2 or 3 is considered a N2. I never remember those things. Okay, so we'll do another pass in the tumor now.
Professor,
Yes,
thank you very much.
you're welcome.